Today we have a very interesting topic, that is therapeutic advances in pain medicine. This is the last episode of Therapeutic Forum for this year. Without further ado, I would like to invite Dr. Krishant Jayasekara, President, Sri Lanka College of Internal Medicine, to address the gathering.
Thank you very much, Ranga. The Therapeutic Forum was established with a clear purpose to create a platform where the expertise of clinicians from diverse specialties can be shared and strengthened to multidisciplinary care. Today's session, of course, the Therapeutic Advances in Pain Medicine, a practical guide for clinicians, focuses on an area that has been overlooked for many years. Pain, though one of the most distressing symptoms for our patients, did not always receive the attention it deserved. In recent years, however, there has been a renewed commitment and humaneness in addressing both acute and chronic pain as an integral component of quality of care. The college, recognizing this need, has dedicated this forum to highlight contemporary approaches to chronic pain management and to revisit essential principles of managing acute pain. These insights, of course, are vital not only for improving clinical outcomes, but also enhancing the comfort and dignity of those whom we care. It's my pleasure to warmly welcome our resource person today, Dr. Gayani Walpola, and to invite all participants to actively engage in this interactive session. Let us take forward what we learned today to uplift the standards of patient care across our institutions. So without further ado, can I invite Dr. Ranga Gunasekara to formally invite the speaker and proceed with the webinar. Over to you, Ranga.
Thank you very much, sir. Dr. Gayani Walpola is a consultant anesthetist at the National Hospital of Sri Lanka. She has work experience in pain management unit at the National Hospital of Sri Lanka and pain management unit Apeksha Hospital, Maharagama, as the consultant in charge. She was the head of faculty of pain medicine at the College of Anesthesiologists and Intensivists of Sri Lanka from 2018 to 2019. She has also served as the national coordinator of the Essential Pain Management Program. Currently, she is an examiner of MD final examination in anesthesiology. While being the chief examiner in MD selection exam in anesthesiology in 2022 and certificate of competency examinations in anesthesia of Postgraduate Institute of Medicine. She is also a committee member to the Board of Study in development of curriculum for postgraduate specialists in pain medicine. Dr. Gayani is the writer of the pain chapter of Palliative Care Handbook by Sri Lanka Medical Association and has contributed in formulating pain management guidelines for adults with cancer by National Cancer Control Program. While working as the pain management in charge, she had a training in palliative care in Singapore. Before inviting the today's speaker, let me introduce some ground rules to the audience. We will be taking up the questions at the end of the session, as well as we will be showing you the QR code to get the CPD certificate at the end of the session. And you can scan the QR code, or you can go through the link that we will be providing in the chat box and fill the Google form, and you will be receiving the CPD certificate in the new course. Without further ado, let me invite Dr. Gayani Walpola to address the gathering. Thank you.
Good evening, and thank you very much for the kind words of introduction. Let me first thank College of Internal Medicine for giving me this opportunity. The topic given to me is Therapeutic Advances in Pain Medicine, a practical guide for clinicians. Before coming to my talk proper, I'll give some few questions which we face day to day. 2 casualty patients were brought to ETU following an accident Patient A with degloving injuries, not complaining of any pain. Patient B, no any obvious injuries, who is screaming in pain. What do you think? Question 1. A is in more pain than B. Question 2. B is an attention seeker. Question 2. In a surgical ward, patient A, a 30-year-old army soldier, B, a 65-year-old retired principal, were brought to the ward from operating theatre following PUH repair. Both surgeries were done by same surgeon and the same anesthetist. A is screaming in pain while B is sleeping. Question number 3. A is in more pain than B. Question 3. In a vascular ward, a 49-year-old man with a history of smoking, 40 pack years with PVD and chronic leg wound, complaining of severe unbearable pain. Healthcare assistance is making the complaint he must be a drug addict. Ward nurse making the complaint that he got addicted to morphine, so the patient was given distilled water and he is responding to this placebo. What do you think? If you get answers like this, I think within next 5-6 minutes, I'll just go briefly what is pain, the types of pain, and the pain modulation. In 1979, the IASP has given the definition of pain. In 2020, the same IASP came out with a better definition. Only they have added one word, that is resembling that. But under this definition, they have given few key notes. Pain is always a personal experience. Pain is subjective. Pain and nociception are two different phenomena. We used to think that pain is directly proportionate to the stimulation of nociceptive. Through their life experience, individuals learn the concept of pain. It is modified effect on the developmental, behavioral, personality and cultural factors. It could be a symptoms. The nociceptive pain is always physiological and it protects us. Some suffers lifelong. Neurological pain always pathological and there's no any protective mechanism. The associated signs are crying, sweating, increased heart rate, blood pressure, and etc. You have seen sometimes some patients, even without any stimulus, they feel pain. Some, there is a stimulus, but the pain is more than the stimulus. And some even with the stimulus, they don't feel any pain. The same IASP has come out with the different terminology. It could be positive or negative symptoms. Hyperesthesia, allodynia, hyperalgesia, analgesia, anesthesia and paresthesia, and neuralgia when there is a neurological symptoms, neurological pain. And in the pain pathway, we all know the transduction, transmission, cortical perception and thalamic perception, that is discrimination of pain, and pain modulation at the dorsal horn, which is by the gate theory A beta fibers, and the same dorsal horn by the periaqueductal gray matter descending tracts. The neurotransmitters are norepinephrine and serotonin. But we don't talk about the brain pain modulation. We do have endogenous opioid, and with so many other factors, we feel something else as to the injury as pain perception. It could be personal beliefs, psychological factors, cultural factors, coping up strategies, social factors, and other devastating illnesses like cancers. This could be the reason that we can explain the behavior of this man. And we have to know left untreated acute pain can go into chronic pain syndromes. And because of the peripheral and central sensitization and neuroplasticity, and we get learned pain. This pain brain modulation and the pain perception and this all these changes are described by this very beautifully in this book, and I think it's worth reading. And as I mentioned earlier, left untreated acute pain can lead to different types of chronic post-surgical pain syndrome or complex regional pain syndrome or different pain syndromes, which is a non-communicable disease which is described in ICD-11. We all know the nociceptive pain. The nociceptors are everywhere. It could be somatic or visceral. The somatic could be superficial or deep somatic, and almost all the covering layers of our organs have the innervation which cause a visceral nociceptive pain. And when there is a damage to this wiring system, we get neurological pain. The damage could be traumatic or chemical, mechanical, or even inflammatory, or the anatomical changes like the crosstalk with our autonomic nervous system and the learned pain, which I talked about, the desensitization and the bud formation and even crosstalk with our somatic nervous system. We can get different types of neurological pain. And it could be neuropathic, or the ISP has described nociplastic pain. The example they have given is fibromyalgia and other types of neurological pain such as migraine. Whatever it is, when anybody comes to the hospital, what they want is, how can I get relief from this pain, and why I'm in pain? As professionals, our main aim is to get what is the diagnosis and what is the treatment for this underlying disease. So keeping all these things in mind, we know these patients can come to us in different types of pain, and anybody can come as a pain crisis. Whatever it is, it's our responsibility to exclude red flags. The pain management is individualized. As any other illnesses, we need a good history examination and relevant investigation, and as I mentioned, exclude sinisters. Pain and disabilities goes with hand in hand, and we need to assess physical, social, psychological, and spiritual disabilities, and we need to have the diagnosis and the treatment plan, and all the patients need follow-up. So we'll come to our topic proper with the case history. She is 59-year-old female, complains of lower back pain for 7 months duration, dull aching pain in the lower back. Sometimes there is a radiation to the leg. Pain score on mobilization was 6 out of 10. We measure the pain score with visual analog scale, numerical rating scale with the color coding. All the hospitals, we do have this measuring tool. Worse in the night and partial relief with the rest, and patient no bowel or bladder symptoms, and she was having been visiting multiple doctors with only little improvement. She lives with her extended family, looking after the grandson, unable to perform household work comfortably, reduced social interaction with the family and the society, and she had complaining of poor sleep, and she had multiple negative investigations already done. So when we see this patient, what comes to our mind? What is the cause? The pain generated. We have to know one patient can have multiple pain generators and multiple pains as well. And it's as Homo sapiens sapiens, because of our erect posture, always common things are common. The simple musculoskeletal pain with facet, SIJ, and other lumbar, the musculoskeletal pains are very common. But at the same time, in the other end, even we get patients with backache completely, the cause is not in the back. It could be even AAA, prostate problem, fibroid uterus, or even a hip problem. Like young patients I have seen with avascular necrosis of femur, and old patients, the fractured followed by avascular necrosis of the femur and piriformis syndrome like. And serious spinal pathologies also can come as only backache, that is TB discitis, prostate CA secondaries in the bone, and multiple myeloma. And we all very happily give the diagnosis of sciatica. That is, not everybody is having sciatica. There can be any other myelopathy, radiculopathy, or Kodai-Quina syndrome due to so many reasons, and that is the root compression or neuropathic or nociceptive pain. So we keeping all these things in our mind, we see the patient. We start seeing the patient with the observation of gait. And it's a must. We need to examine general examination and system examination, and with a special attention to the neurological and musculoskeletal examination. And documentation is very important, because once you start treatment, we all know, they come and tell us, yes, after your treatment, now my backache has gone, but maybe due to your treatment, now I am having a knee pain. So if you document all the complaints, pains, and very good neurological and musculoskeletal examination, and your plan, and patient explanation is very important in managing these kind of patients. And you must be knowing the different special tests are available in the examination of the musculoskeletal system to differentiate whether this is originating from hip, SIJ, or facet. SLRT, Faber's test, femoral stretch test, and there are so many other tests available. By doing these tests, we can have an rough idea about where is the origin. And as a must, I have told at the beginning, is by the history and examination, we need to exclude red flags. In our patient, when we examine the patient, the positive findings were suspected left SIJ and left facet with the positive SLRT. Now, how do we manage this patient? Does she need MRI? I know the current trend. Even most of us, even now, even without seeing the patient, just WhatsApp me the MRI report. But we have to keep it in our mind. These investigations all depend on the patient's history and examination. Some needs blood investigations, and if we suspect bony problems, so we may ask X-rays, and even further management, we might need CTs and soft tissue problems. If there are any red flags, yes, as early as possible. Otherwise, when we can't manage, we might ask for MRI. The other investigations like nerve conduction studies also, some patients we may have to request. And when we get the problematic patients, when we referred, they might need other biopsies and cultures. As pain consultants, we may go for diagnostic or therapeutic nerve and joint blocks. So median facet joint blocks and median branch diagnostic blocks we do sometimes to get the diagnosis or confirm the diagnosis. In the management, we all know we don't have one single ampule or one single tube to manage these patients. As these patients are having so many problems, the management is multidisciplinary and multimodal. Always we can't forget about we need to have the evidence-based management, and it should be patient-centered. So we know the pain pathway and where our different drugs are acting. At the spinal cord, the drugs and the descending inhibition, how the drugs can act on the descending tract and the first order neuron, second order neuron, and on the pain modulations. Keeping these things our mind, we start multimodal analgesia with the help of WHO analgesic ladder. When there is a neurological pain, we may have to start adjuvant therapy. It could be anticonvulsant, antidepressant, steroids, even bisphosphonate in the bone secondaries and osteoporosis, and cannabinoids coming into the scene. And as anesthetic drugs, we use ketamine, lidocaine, and even neuroleptic drugs in the management of these patients. And in our patients, it is chronic nociceptive and neuropathic pain. So we started in the stepping up in the ladder. That means when we go for the second step in the ladder, we have to add the first drug, not that going for the next one. But with this kind of neuropathic and nociceptive pain, the chronic neuropathic pain, we should never start strong opioids, because if we start that, there's a high chance of patients getting addicted to opioids. And regarding interventional pain management, is if it is relevant, it could be diagnostic or therapeutic blocks can be given. I'm very fond of this book, really speaking, and it is ANSCA, evidence-based pain management. Now we do have 5th edition, came in 2020, and every 5 years they come out with a new edition, and we are waiting for the 6th edition in 2025. So they beautifully described the unchanged evidence compared to the previous one and what is the level of evidence. So antidepressants, particularly, they have done most of the studies with SNRI inhibitors, duloxetine, and a treatment of chronic lower back pain, which is unchanged evidence, that is level 1. In our patients, as drug treatment, we started paracetamol, and as adjuvants gabapentin, and antidepressant amitriptyline as a pain management dose. And because patient went into muscle spasm, we had to start baclofen for a short time. And we explained the conditions, and we asked the patient to have a pain diary. As patient went into a severe pain at one or few times, we had to go ahead with short duration of weak opioids, tramadol, to manage side effects. We had to start other drugs as well. And interventional therapies available for us in our unit: trigger point injection, facet SIG injection, epidural root canal injection, and diagnostic or therapeutic median branch block, and radiofrequency ablation or alcohol ablation for this kind of patient management. So our patient, we gave facet joint injection. You can see the Scotty and the Scotty dog, and this Scotty dog ear is the facet joint and eye is the median branch. So we can go ahead with the diagnostic median branch block, and we did it, and we were waiting for the radiofrequency ablation after, if patient recurs her pain. And SIJ also SIG injection with steroid we gave, and also radiofrequency ablation can be done for this joint. And whatever you mention can be used as non-pharmacological methods of management. So in our patient, we know after excellent discussion, we were able to analyze all the other problems of this patient. And patient had activity changes, which is physical changes, and thought and belief changes, and all were leading to mood and sleep disturbances. And in our patients, it's very common. They are really scared to take long-term pain medications and these adjuvant therapy, thinking of side effects, and because they don't know this is a non-communicable disease. And they are really scared of the side effects. And there was impact on the work, home, and family, and also ultimately the financial problems as well. So after considering all these issues, we were able to manage non-pharmacological methods, patient education, exercise, and physiotherapy, and lifestyle modification, psychological therapies, social and occupational rehabilitation, and complementary therapies. When we come back to the novel therapies in neurological pain management, the novel therapies described in mainly identification of pain mechanism, pharmaceutic innovations, neuromodulation strategies, personalized pain management strategies, and regenerative medicine. And especially when we try to analyze the biologics and regenerative medicine, neuromodulation therapy, and novel pharmacological therapies, I'll just glance. And in Sri Lanka also, in some centers, neurosurgeons are doing spinal cord stimulation. This is invasive method of pain management, even after spinal cord transection, chronic neuropathic pain. To control the long-term relief in chronic pain, it is highly invasive and costly. And deep brain stimulation also proven effective in the management of refractory pain. The non-invasive methods are transcranial direct current stimulation, and it is not that specific, and sensitivity is also less. And transcranial magnetic stimulation technique also the same. To overcome this problem, they have started doing transcranial ultrasound stimulation, non-neuromodulation therapies, which is precise and non-invasive method. Novel pharmacological therapies. Actually, they were trying to find out, even with the AI-guided prediction of pain progression and development of chronic pain, and the specific receptors and targeting the receptors in the management, the selective now 1.7 sodium channel, because we know sodium channels are the neurotransmitting in the pain pathway, and cannabinoid receptors and N-type calcium channel blockers. And intrathecal drug delivery system, actually, we in our hospital even, we had few patients using baclofen and preservative-free morphine. Using intrathecal drug delivery system, we can use very minute dose, and we need to follow up these patients once a month. And that is good in the same like chronic neuropathic and even the severe spasm due to spinal cord injuries and transections. And monoclonal antibodies and even biologics. That biologics, we all know that the patients maybe RNA, DNA, or nucleic acid. So no side effects, minimum side effects, and patients own the cells, and like stem cell therapies. I think stem cell therapy also some neurosurgeons were practicing in Sri Lanka, and the monoclonal antibodies is really very minute, so mimicking the their own biologics. So they are trying in the treatment of chronic pain. And PRP, now I think we all know, and most of us are practicing for most of the conditions. In chronic pain, also like tendinopathies, and when there are damage, and when patient is high risk of developing chronic pain, so and also the researchers are there for neuropathic neurological pain as well. And yes, it is biomarker guided and machine learning based pain prediction, AI guided, and it is patient centered and multidisciplinary care. And the future will be personalized, targeted, non opioid based pain management. So we will move to the second case, which is a cancer patient. Actually, this is a bit long back. I managed this patient, so I thought of talking this patient because I think I can talk. Uh, when I'm talking about this patient, I can talk what I want to tell you. She is Mrs. K, 48-year-old nursing officer at NHSL, has taken treatment for gastritis on her own for epigastric burning pain for 6 months duration. In July 2018, she developed sudden severe abdominal pain with vomiting, which resulted hospital admission. She was diagnosed to have colonic carcinoma with liver mets. Surgical resection and anastomosis was done for large abdominal mass in the same month. Post-operatively, she was referred to pain management unit for post-operative pain management. And they had the plan of going ahead with bone scan and Apeksha Hospital referral for further management. On admission to pain management unit, she complaining of dull aching pain over the surgical scar, severe pain of 9 out of 10, and diffuse abdominal pain, which was severe, it is 7 out of 10, and lower backache of moderate pain, which is 5 out of 10. All the pains were worsened with the movement and no radiation, and the patient was not responding to treatment. On examination, we also could detect only abdomen and lower back tender, and all the other findings were normal. And investigations we had from the ward and bone scan found multiple pelvic secondaries. And other problems that we were able to detect. The physical, she had poor oral intake due to anorexia and nausea with poor sleep. Psychological, she was depressed with mood fluctuation throughout, mostly the low mood, always thinking of her 2 kids. These 2 kids were very small kids in 2018. She knew that she has cancer, but needed to be cured after treatment. And social history, that is as a norm when they are having this kind of cancers, the both families, there are conflicts are happening. And we were able to detect the abdominal pain, that is surgical and cancer pain and bone pain, and were acute and severe pain. So we started treatment, IV morphine. Until she's pain-free, we had to give 18 milligram. Because what I have to tell you is, there's no dose of morphine. So we learn the morphine dose is 0.1 to 2 milligram per kg, but all depend on the age and the patient's conditions. Until they are in pain, they will never go into respiratory depression. And even we can diagnose the dose that she need with the intermittent boluses or even patient control analgesia. And we started the regular morphine 5 milligrams subcut. And always my advice is to prescribe morphine for these kind of patients PRN basis, because at any time they can go into acute kidney injury, sepsis, and vomiting, dehydration, and sepsis. So, if we write regular 6 hourly, whatever the condition, the nurse will give the drug for the patient, then patient will get side effects. And the nurses also need same education regarding the side effects, pain score, and the sedation score in the patient management. And then they have to give the drugs if there are no such what I have previously mentioned problems. So they can continue. If patient is in pain, they can give the drug. And as the other pharmacological management, we gave paracetamol and the gabapentin also. When we are starting, we have to start with very low dose, maybe 100, 200 once daily dose, and gradually, once patient is stabilizing, we can go ahead with the maximum dose. The written maximum dose is even 3,600, but in Sri Lanka, I think I have gone maximum of 600 TDS 8-hourly dose. And any kind of antidepressant or SSRI, SNRI inhibitors, depending on the patient's other conditions. And again, PRN basis, we start diclofenac suppository. And pharmacological management is a cornerstone, but non-pharmacological management also need to be started with the pharmacological management. And reassurance of the patient was the most difficult part in this kind of patient, and different massaging technique. And once her pain was controlled, she was happy, and she was able to join our unit and helping us. Actually, that is also a kind of managing with peers, and they can work as ambassadors in the management of other patients. They can explain, they can give lectures, they can work as ambassadors in the management of pain patients. Yes, she used to spend the time with us with a respect and heavy heart. This is her, and her pain management was well controlled with our treatment, and pain became 0 to 1 at rest and very acceptable on mobilization of mild pain. And her mood fluctuations were present, and she started taking orally, but unfortunately she started rising serum amylase within next few days, developing acute pancreatitis, and they were unable to send her to Apeksha Hospital. And ultrasound abdomen revealed that the dilated CBD, and gradually within weeks, patient became icteric with abdominal distension, and patient became more and more depressed and complaining of severe pain with even difficulty in breathing with ascites. And CT showed obstruction at the common bile duct, and her pain score went up to again 10 out of 10. And for cancer pain, the drug of choice is oral morphine. So we can start the oral morphine, IR, immediate release morphine, even 4 to 6 hourly. And always we have to keep it in our mind, we have to prescribe something for breakthrough pain. And also, patient control analgesia also one method that we can diagnose the patient's required dose and how much that we have given, and then we can decide the 24 hours required dose of oral morphine to our patients. But unfortunately, this lady totally refused morphine, if I'm correct, and we had to go ahead with fentanyl patch, which was 50 mics, releasing 50 mics per hour, and for 3 days. And in the world, we are having buprenorphine patch, which can be changed over every 5 days. And before starting fentanyl or any these kind of patches, we need to explain the patient, family, and the caregiver very well all the side effects and what to be what have to be done if we detect any problems with these drugs. And endoscopic stenting was done with ERCP by surgical team, and decision was taken to manage the patient conservatively with the palliative care referral. And we gave the celiac plexus block with the plan of radiofrequency ablation if she develops pain again. And with the use of fluoroscopic guided, we managed to give celiac plexus block. And the other management was, and as I mentioned earlier, it was very difficult to reassure her, and she had fear of death, fear of isolation. Even she didn't want to stay 1 hour alone in the ward because fear of death, and wanted to be cured. And we have done the psychiatry referral and many other ways of social support given. Pirit chanting and dana ceremony and felicitation ceremony was organized by our unit, and with the help of the hospital staff and her family, our nursing team was able to make all the arrangement for her WNOP. And family education was continued with daily updates. And as usual, the all the aspects were addressed with the help of other patients and the staff. And what we have to know, when somebody is having cancer, the pain could be due to the origin of the cancer itself, the bleeding into the tumor, the tissue necrosis and mass effect, and the wound, chronic wound, and also dissemination of the tumor can do same things in other different places as well. And the secretory tumors can cause different kind of issues as well. And unfortunately, all the treatment methods can cause pain. The chemotherapy induced pain, radiotherapy induced pain, and even immunotherapy. And the indirect causes of cancer related pains are like immunosuppression can lead to activation of herpes zoster and post-herpetic neuralgia, and backache due to one secondaries and due to other causes, and infection and catheter-induced pyelonephritis. So, keeping all these things in our mind, we need to follow up the pain patients when we get patients with cancers, and we can't forget about the lifestyle modification. And as method of pain management, reduce stress, get into nature, stay physically active, and like as I mentioned earlier, they can do whatever they are happy to work and get enough sleep. We can't ask them to sleep, but it's our responsibility to make the environment that they can sleep. The patient explanation and the bystanders, caregivers explanation is very important in the management of cancer pain. And diet and nutrition, I think now everybody is talking about the almost all the disease and cancer and pain management also. It is coming up, and good healthy diet eventually reduce weight, and also it's proven and it reduces the chronic pain. And alcohol and smoking is also very well known, and it can cause more pain. And patient control analgesia, as doctors, we have to know how to put patients on patient control analgesia and how to use this machine and how to assess, analyze the after 24 hours the required patient's pressures and the patient's required dose and how much the machine delivered. And usually we don't start the baseline flow infusion and only the PCA, but in the ICU even we can use the with the basal flow and PCA, and also in terminal care again with the consent of patient we can give even a sedation and morphine with this same machine with the basal flow. And we know magnesium is also, we were talking very interestingly for a few years ago in the management of chronic pain and acute pain, yes, as a nutrient as well as the management of acute pain, yes, and also in the management of chronic pain as well. And ketamine and lignocaine. So we started practicing ketamine infusions in the management of neuropathic pain and for almost all acute post-surgical pain as a ketamine, sublingual ketamine, and it is proven in the management of chronic pain also we can use ketamine. And lignocaine too, lignocaine we know it is antiarrhythmic and can cause arrhythmia, but IV lignocaine therapy, other than regional techniques in the interventional pain management, we give to our patients as infusion. If they don't have heart blocks, we give lignocaine infusions for our patients when they are having cancer pain also, and very commonly for neurological pain. And 5 milligram per kg lignocaine infusions we can give daily or 1 hour, 5 days or weekly. So many different regimes are available, so we can practice. And we practice with very good monitoring, but according to the literature even they practice without monitoring. And the questions, I think there is a time for the questions. The summary: pain and nociception are two different phenomena. Pain, brain modulation led to chronic pain syndromes, same as it can behave to leading to chronic pain syndromes, as well as this pain brain modulation we can use to treat the pain as well. And treating pain is humane, and always red flags need to be excluded. Novel therapies are focused on the patient-centered management. Innovative therapies and personalized medicine marks a transformative era in neurological pain management, improving patient outcome and quality of life. So these are my references, and now time for questions.
Let me read the first question. What is the difference between addiction and tolerance?
Yes, the tolerance. So when we start any drugs, with the time we need to increase the dose. So because they are whatever may not be the pain, they are the drug dose is going to get increased, and we have to know. So to avoid tolerance we can change like opioid rotation, and we need that is multimodal analgesia, and we go for interventional pain management techniques like to avoid the tolerance. And we have to, at one point we have to understand, so the tolerance happens mainly with even intravenous remifentanil when we give intraoperatively. Also, they can get hyperalgesia and tolerance. So the addiction is after knowing that if I take this, that is harm to me, but still they ask for it. And what you have to know, if you treat acute pain, that's very, very hard with opioids, maybe morphine, maybe fentanyl, very, very hardly they go into addiction, because we treat pain and we have to keep it on our mind that the acute pain is something that going down. So we have to keep every day check the drug chart and reduce the dose and stop it at one point. But if you start treating like backache, chronic neuropathic pain, chronic nociceptive pain with opioids, yes, there's a chance of them going into addiction. And there's a thing called acute neuropathy. That is different. When even after trauma, they can come with acute neuropathy. In that case, even you can treat with anything, even opioids, neuropathic drugs, nociceptive drugs, and because the acute pain could be nociceptive and neuropathic combination, right? So to prevent addiction, we have to we should not give opioids for chronic neuropathic pain. And when we detect, and another thing of addiction, I would like to say, if we get a patient even with addicted to morphine, if patient comes with some other reason, acute pain, we may have to give higher dose, because we know the patient is addicted, and even patient will not get any side effects to our normal dose, and they will not have to respond to our normal dose. We may have to go for higher doses. And the addiction management is different, and we are not managing. Actually, we have to refer this patient to psychiatrist or psychologist. Thank you.
Is there a role in using other means of analgesics, such as...
Sorry, I didn't get.
Is there a role in using other means of analgesics, NSAIDs or opioids, in a patient's on epidural analgesia for post-operative pain relief?
Yes, definitely. It is. So why we put epidural analgesia is to not, it is not that not to give other drugs, because they will be conscious and they will be the walking epidural. With the epidural, they can walk, because to avoid post-operative complication, they should be able to move out of the bed. And it is one thing that if there are any contraindication for morphine, yes, we have to not to give morphine like very obese OSA patients. So we are practicing opioid sparing anesthesia. But in multimodal analgesia, so if they are on epidural, we can use paracetamol and NSAIDs. Then we can reduce the epidural dose, because if you increase the anesthesia, if you talk about the surgical anesthesia, surgical analgesia and post-operative analgesia are two different things. Surgical anesthesia, we can give very high doses of epidural infusions. Surgical analgesia, we reduce. If we give anesthesia and IV opioids, we give reduced dose as infusions to manage these patients. But as post-operative analgesia, it is not that severe. So we reduce the dose, maybe 0.1%, 0.125%, or even some use 0.065% bupivacaine. And we can add fentanyl, we can add epidural preservative-free morphine, and give continue the epidural infusions, the bolus of morphine, or with the epidural infusion, fentanyl as with the infusion. But for your question, yes, we have to practice multimodal analgesia in managing patients. If no contraindications, we have to give almost all the drugs.
And the next question is, how do we identify and differentiate the pain of muscle spasm from other pain types before starting baclofen?
Yes. So actually, if you have seen 5 patients, you will see, so they start with, for example, let's say backache, then they leg pain and knee pain and calf pain. So because of when there is a stimulus or inflammation or any other trauma, all the muscles goes into spasm. So it's very difficult, even the patient, to exactly say this is I'm having pain here, because anybody, I think you all, most of you may have experience in shoulder pain, and then elbow pain and hand pain and the whole arm pain. So that is mostly because of the muscle spasm. And the origin may be some levator scapulae tenderness and spasm, or the nerve irritation or something. So when you touch, so you will see the tender points. And when you touch the muscle, you can get an idea about this muscle is in spasm. So it is very hard, and even sometimes you can see just small, tiny, like I can't say tumors, like small, tiny things that we can feel over the muscle. And those are indications for trigger point injections even. And with the muscle relaxants, I think if there are the people practicing old medicine, you can remember that we were giving diazepam those days. Now it is replaced with short-acting drugs. And with these muscle relaxants and even good massage, heat therapy, cold therapy, and it's very difficult to get rid from this muscle spasm within first massage. So the patient might need 24 to 48 hours. Sometimes when muscle is relaxed, so we can get the proper diagnosis of SIJ and the piriformis syndrome, like the pain, the generator can be diagnosed when we were able to get rid from this muscle spasm.
Okay. What are the non-pharmacological methods we can use within limited time in emergency department?
RICE. So I think we practice RICE, rest, ice, compression, elevation, and so splinting. Everybody, the splinting, so rest, and even people, I can't say start massaging and therapy, and interventional, like emergency department. I have seen enough patients with fracture femur. If we can go ahead with fascialica block and even fascialica catheter, interventional pain management also can be start using in the emergency department. If we are confident and we are competent, we can start practicing anywhere the pain management and even PCA, patient control analgesia, even whatever you can. Non-pharmacological, so sorry, you ask for non-pharmacological, they are the well-known is RICE, rest, ice, compression, elevation. And we can't ask the patient to meditate at that time, but if you were doing meditation and mindfulness, so when they are in pain, they can do that. Not we start doing that when we are in pain. We can't start doing it when we get injured. If you are well trained, you can do it.
We have an interesting question. What are the complications when morphine given via IV route instead of SC route?
Yes, you have to have idea about the drug distribution. When we give IV, the plasma concentration is achieved within seconds, and subcutaneous it takes little bit more time. So if the plasma concentration is achieved within seconds, the action also achieved within seconds, and we talk in within 5 minutes the drug action we should expect. And if patient doesn't have the action within 5 minutes, we can go ahead with the next dose. Subcutaneous, not that quickly get absorbed. So we are not supposed to give subcutaneous and the next dose in 5 minutes. We have to give the dose like 5 milligrams, 7 milligrams, 8 milligrams. If you are giving subcutaneously, the IV, so you have to go ahead with minute doses and boluses and wait for the response, and we can stop giving drug because when patient is pain free, and that is the difference. And patient control analgesia also one mode of IV.
What is the status of patient control anesthesia for cancer and post-surgical pain in Sri Lanka?
Yes, it is well known, evidence based, especially females. I think if I'm correct, the evidence are with female because of the satisfaction and pain control. And most of the hospitals, we do have PCA machines, and National Hospital, Apeksha Hospital, and I think other Gaul, Kandy, but I can't comment of all the hospitals in Sri Lanka, but we do have in the ICU separately, pain unit separately, we do have patient control analgesia machine available. So if the ward want, even from the pain unit, when you write the referral to the pain consultant about the patient, and they will issue the machine, and we are having instruction or leaflets, and they will teach you and how to use. And also another thing, patient control epidural analgesia is also available, but we don't use it frequently. You can get to manage patients post-operatively in the ward. Yes.
How to control pain because of anxiety after spinal anesthesia in pregnancy and young?
Sorry?
How to control pain because of anxiety after spinal anesthesia in pregnancy and young?
Right. Pregnancy, usually for spinal, I think almost all you add fentanyl. Right? Am I correct? And if we can give, so as preventive analgesia, preemptive analgesia, we give paracetamol for everybody 2 hours before for cesarean section. And again, at the end, most of the stations, they give tab blocks. So that is post-operative and diclofenac suppository in the before sending them to recovery. And anxious, like, so we, depending on the institution, so as preemptive analgesia, some may giving ranitidine and maxalone, and but we don't give usually diazepam for these pregnant patients. And any other, I don't think that we do have to give any other thing if they are pain free. As anxiety, to relieve anxiety, we don't give any other thing, but during the section, if they feel pain, ideally we have to talk to the patient, and we may have to convert into general anesthesia. But in England, definitely we have to convert into general anesthesia if patient feels pain intraoperatively at any point, even after the delivery of the baby. But in Sri Lanka, I have seen, I can't comment, because they give ketamine, midazolam, fentanyl, and so many drugs intravenously. And so I have seen you telling it is just you're having a baby. So when see this, you're having this beautiful daughter or son and verbally talking, and I have seen. But I can't advise you to go ahead with general anesthesia for all the patients, but in England, we have to go ahead with general anesthesia.
Is celiac plexus ablation available in Sri Lanka? Celiac plexus ablation.
Yes. At National Hospital Pain Clinic, we have started long before, and greater and lesser splanchnic nerve RF ablation, and the current pain consultant is continuing all these methods.
This is a bit long question. What are the aspects addressed in CBT for pain, Does it work for acute pain also? Can anything similar to CBT given by physicians other than counselors?
I don't know really because I have participated for CBT sessions for learning CBT, but I have never practiced. The psychologist and psychiatrist in our unit doing these things. But mindfulness, yes, that is very good therapy. And as I mentioned, so if you start practicing mindfulness well before you get pain, that you can use that when you are in pain. As I mentioned, not when you are in pain, you can't start.
Yeah. So this is an important question, I would say. End of life full palliation with syringe pumps, are we using in Sri Lanka? Is there any legal provisions? I'm sure that the people who have practiced in UK, so we have been using syringe pumps.
Yes, legal provision. Actually, the palliative care legals, I think now they are in the process of making most of the things legal. But I have to say, as a pain consultant at Apeksha Hospital, most of the patients, after explanation, talking, and
Yeah.
patients, because we all have to accept patient autonomy. That is the one we have to respect. And if all are in agreement, I have start end of care sedation with midazolam. Actually, we should not use morphine as sedative. Morphine is a painkiller, and midazolam morphine infusion and in the wards. And I have started, and I think nowadays also they must be practicing, but I can't comment. Now, most of the hospital palliative care units are well up to the standard. They are doing palliative care with the discussions with pain teams, Apeksha Hospital especially. And I think I can't talk much about the palliative care, the current situation in the palliative care. Sorry.
Next question is about IV lignocaine infusions. Given the risk of cardiac arrhythmias, does it need continuous monitoring or periodic monitoring?
What I do, I practice with continuous monitoring and even OPD basis, that pain clinic basis, I did and I still do it, still am doing, and that is 1 hour per day. So I continuously monitor the patient and clearly explain the patient about the side effects of local anesthetic toxicity. Features of local anesthetic toxicity. Actually, I have faced 1 or 2, not 2, more than that, patients who start developing local anesthetic toxicity and I have to stop. So, with the clear explanation and monitoring, I do practice, and pain clinic also practicing. But as I mentioned, the guidance, the guidelines doesn't say so.
The next one is, how effective IV paracetamol in post-operative pain management?
IV paracetamol, oral paracetamol, when you compare with the bioavailability, there's no much difference, because I think oral bioavailability is more than 90% if I'm correct. But we have to take to the empty stomach because it get absorbed in the duodenum or jejunum or somewhere. If we take after heavy meal, it takes more than half an hour to 1 hour to go to reach that part. So it should be taken to the empty stomach, more or less equal, maybe a little better IV. If it is 90% and 100% we say, and post-operatively, so my advice, all the patients coming to the theatre as a preemptive analgesia, you have to prescribe paracetamol oral 2 tablets or the dose, 15 milligram per kg dose, and post-operatively, if patient can't take orally and intraoperatively, we can go ahead with IV paracetamol. And in ICU patients, because most of the patients are not taking orally, so we give IV paracetamol. Otherwise, as early as possible, that we all know the price difference, and always oral is the best route for any drug. So we have to give oral as early as possible, as much as possible for patients.
The next one is what is the best guideline that you would suggest to read up in managing practical pain management? What is the best guideline to read up?
Unfortunately, we don't have that specific guidelines. Actually, it may be our fault that we have not done that such a guideline. We do essential pain management programs, EPMs, and island-wide, and try to educate doctors and nurses. And we are having trained pain nurses, and we are in the process of starting a pain certificate for medical officers. I think so. We give our guidelines means our experience by different means like this, but I don't know. I don't have such something to recommend, but I really like that and the evidence-based pain medicine book.
What is the role of preemptive analgesia in major surgery? If so, what types of analgesia drugs could be used pre-operatively?
So I think I mentioned already, we give paracetamol for everybody. Depending on the requirement, you can start NSAIDs, ibuprofen-like drugs preemptively, and we put epidurals preemptively and can give, it is also evidence-based, giving epidural first injections before surgical scar is started. So those are the things that I can recommend.
And when we are practicing abroad, we have been using oxycodone in renal impairment patients. So the question is, do we have oxycodone in SL, and can we use?
No, not in Sri Lanka. And it's a well-known common drugs using in developed world.
Yes. Can we use fentanyl patches in them?
No, fentanyl patches. Actually, we should never use fentanyl patches for acute pain, because as I mentioned earlier, acute surgical pain is something going down. And fentanyl patches, so they can get side effects when they don't have pain. The drug get released from the body. It is not meant for acute postoperative pain. That is for cancer pain and chronic neuropathic pain. Also, we don't prescribe fentanyl patches. So we
no, the question was actually the part of the previous question, whether we can use fentanyl patches in renal impairment patients.
Yes, the doses are different, because 15 milligrams per kg per hour is available, 25, 50. So you can use any combination. 50 and 12.5 is 75, 25, 12.5 is 37.5. So we can use combinations and the frequency. So you put the one, and the next day you can add the second one. With your experience, you can play these drugs. And because the renal failure, it's metabolized, and it is not like morphine. So we can use the low doses always when we are managing patients with renal failure. What you have to know, the metabolism and excretion of the drug, and keep eye on the patient and knowing the side effects. So any drugs, even morphine, we use for renal failure patients, but always should be the reduced dose.
So next question is, I think mostly important in the GP practice. When the patients are allergic to paracetamol, when they can't be using NSAIDs, what are the other options available?
Right. Actually, so with my experience, what I have to say, allergy, you have to define allergy. So it is not the side effects. So you have to ask from the patient what you have had really. So even some patients we see amoxicillin augmenting allergy. What you had? It's diarrhea. And this well-known salbutamol, I am allergic to salbutamol. What? It's tremor. So exactly, number one, you have to take a good history and real allergy. So if patient is really allergic, if patient is getting features of anaphylaxis or allergic, so definitely we can't give. So there are very rarely I have seen patients who had allergic to paracetamol, and so in that case, as you said, we can go ahead with NSAIDs, mefenamic acid. But if somebody is allergic to all the drugs, so I have seen we can try with like gabapentin, though it is not exactly not meant for neuropathic pain, and we can try, but so I can't say that you have to go for other drugs like opioids for, and if it is severe pain, like moderate pain, we can go for tramadol.
Yeah. Do we have CT guided steroid injections for neuropathic pain due to canal stenosis?
Yes, root canal, epidural, all we do under fluoroscopy.
What is the superior between baclofen and quizartinib in muscle spasms?
Oh, I don't know. You have to read.
Yeah, yeah.
But I practice tisinidine in private sector. Government, we don't have tisinidine. We give baclofen.
Right. In the absence of any more questions, I would like to thank Dr. Gayani Walpola for her excellent presentation. I'm sure our audience, we have had, even during this catastrophic event that we have experienced in past few days, we have had more than 200 participants for this webinar. And I'm sure that our participants have vehemently got what they have required through this webinar. And I again thankful to Dr. Gayani Walpola on behalf of President and Council of Sri Lanka College of Internal Medicine. And good night. And to the audience, thank you for joining us. And we will be joining you in the new year as the next chapter of Therapeutic Forum in January. Good night. Thank you very much.
Thank you very much.
Thank you.